This soft tissue contracture is very, very common in the cerebral palsy, especially in spastic cerebral palsy. They require this, as we know that in cerebral palsy, biarticular and multi-articular muscles are primarily affected. Monoarticular muscles are very, very less affected. So whatever we are doing to do on biarticular, multi-articular muscles. And cerebral palsy is a multi-level problem, so we have to manage it single-level, multi-level surgeries. And surgical corrections should not be done at very early age. That should be avoided before 7 years, with little exception like the hip dislocation, subluxation. Surgery only in spastic cerebral palsy and mixed cerebral palsy where the spasticity contracture is there. But before embarking on the surgical intervention, clinical decision making is very, very important. A detailed physical examination, including the objective and 3D gait analysis. It is very important to differentiate between spasticity and muscle shortening because we are not going to do anything by surgery, the management of the spasticity. By surgery, we are managing contracture only. And ultimately, examination under anesthesia is very, very important. Sometimes we are evaluating the child. The child is very, very afraid of in the chambers. It's not giving correct measurements, how much is the tight. And surgical dose will be dependent upon the evaluation of the objective gait analysis and examination under anesthesia. And we have to set up the goals, what we require. The indication of soft tissue surgery in cerebral palsy is short musculotendinous length, that is a contracture, and very, very rarely in imbalance and overpowering muscle in weakness where tendon transfer is required in certain muscles, just like upper limb and foot surgeries. Common muscle contracture in the lower limb, that is psoas major, adductor longus, hamstring, and gastrocnemius, on 4 topics we will be discussing on here. This common soft tissue surgery in cerebral palsy, tenotomy, that is complete cutting the tendon. Not 2 days this is not being done. Gentle lengthening of the tendon, it is required in muscle is very, very shortened, and intramuscular tenotomies is very, very useful procedure in cerebral palsy. And myofascial release, especially in the gastrocnemius surgeries and tendon transfer in some places where the opposite muscle is very, very weak. First muscle we are going to do have psoas lengthening. Why we have to do psoas lengthening? Thomas test is used for the hip flexor tightness. It is done in supine position on the side of the crouch. If flexion deformity is more than 15 degree, excessive anterior pelvic tilts, and diminished extension of the hip in mid and terminal stance in gait analysis, then we have to lengthen the psoas muscle. There is 2 techniques. That is, one is at the pelvic brim or above the pelvic brim, intramuscular tenotomies, a very, very useful procedure that should always be done in the ambulators, that is GMCS 1, 2, 3. But we can do complete tenotomy at the lesser trochanter if child is not ambulator like the GMCS 4 and 5, but that complete tenotomy should not be done in ambulatory patients because the psoas muscle is very, very important hip flexors. This is the surgical procedure. There is 4 centimeter oblique skin incision just above the inguinal ligaments. After getting the skin incision, we will be getting the anterior abdominal muscle. After separating the anterior abdominal muscle, we will get the femoral nerve. Femoral nerve can be retracted at the middle and we will get the iliopsoas muscle. In the iliopsoas muscle, you will be cutting only the psoas tendon, not the iliac muscles. So that after the cutting, you can check that how much the hip flexor deformity is remaining, and that hip flexor deformity will be corrected completely. Now come to the adductor tenotomies. Why we need the adductor tenotomies? Adductor tenotomies to prevent the hip subluxation and hip dislocation in some cases. If hip abduction is reduced in swing phase, abduction range of less than 40 degree in one or both of the hips, migration percentage of 30 degree in one or both of it, and usually it is required bilateral sides. In physical examination, we have to see that the adductor problem is because of the hip adductor or some other muscles. If you are doing range of hip abduction with flexed knee and hip, that will show that adductor contracture is there. But we are managing this hip abduction range with the hip in neutral and flexed knee. Then it is because of the adductor and gracilis muscle. But if you are examining the range of hip abduction with hip knee both in extension, that it means that can be due to the adductor and gracilis and medial hamstring. So that is very, very clear we should be there that this adductor tightness is looking, it is because of adductor contracture or something else is there. Adductor tenotomy is done by the 2 centimeter incision distal to adductor origins. The release of the adductor longus and sometimes gracilis very, very rarely we require adductor brevis. We have to spare obturator nerves and adductor brevis. Our goal is to achieve abduction of 50 degree abduction, usually done bilateral sides. In the hamstring, that is the incomplete extension at the hip and knee, and terminal swing is the indication of the hamstring tightness, that it should be tested in the gait analysis. And physical examination, bilateral popliteal angle is very, very important. Single side of popliteal angle can give these false results. Bilateral popliteal angle more than 30 degree in facial exam under anesthesia, it is the right indication by the hamstring shortness. There is two tests is there, bilateral popliteal angle and unilateral popliteal angle. There is angle between the thigh and up to the knee, that is tibia, it is the popliteal angle is there. There is bilateral popliteal angle give correct measurement of the hamstring length because the anterior pelvic tilt is been neglected, relieves. It is also essential to differentiate between the knee joint capsule and hamstring contracture. Knee joint capsule, you can test it in the complete extension of the knee joint in the supine position, where the hip position is this 0 degree flexion is there. Surgical dose is very, very important in the hamstring muscle. If this mild knee dysfunction with less than 5 degree of knee flexion deformity, then we need only medial hamstring lengthening. But if there is flexion deformity 5 to 15 degree along with the hamstring contracture, we can tackle it with by semitendinosus transfer to the adductor magnus along with semimembranous lengthening. But if there is extensor lag is there, with flexion deformity of up to 30 degree, we can go for the supracondylar osteotomy with patellar tendon shortening and advancements. If there is hamstring contraction is also associated with knee flexion deformity up to 30 degree, we can go for the supracondylar extension osteotomy, patellar transfer with shortening osteotomy of the femur, because we have to save the hamstring as much as possible, because cerebral palsy children always have muscle weakness. We have to spare as much as muscle as possible. This surgical technique I brought from the literature, that is myofascial release of the semimembranosus and intramuscular tenotomy of the semitendinosus, the mild cases. In moderate cases, we can go for the myofascial release of the semimembranosus and transfer of semitendinosus to the adductor magnus. Surgical technique, semimembranosus is lengthening by the 1 or 2 stripes in the fascia over the distal muscle, followed by the gentle extension of the knee. Gracilis and semitendinosus lengthening usually done by the jet lengthening, sometimes by the intramuscular tendon lengthening if there is very mild contracture is there. But we have to spare the bicep femoris most of the time, because there is the risk of knee recurvatum and risk of increased anterior pelvic tilt if you are doing the bicep femoris along with that. That is simple jet lengthening of semitendinosus can correct mild to moderate knee flexion contractures. If there is more than contracture is there, we can go along with that, that is stripe lengthening of the semimembranosus. You can see there is stripe lengthening of semimembranosus and the intramuscular tenotomy of the semitendinosus. We can get it, all these hamstring length can be maintained by this technique. In semitendinosus transfer, we have to cut the semitendinosus at the insertion where, and we have to separate out the adductor magnus muscle, and we can take it from the posterior to the medial side and tackle to stitch to the adductor magnus. In the nearly 30 degree hip flexion at this position, and that's proper tightening should be there. By this technique, we can manage the hip, there is pelvic tilt problems in this hamstring muscle lengthening. The most of the time, hamstring is of normal length or over lengthened. So, as much as we can avoid this hamstring lengthening, it is possible, because overdose of the hamstring lengthening can become disastrous for every children with cerebral palsy. Hamstring contraction is one of the cause for crouch gait, but other factors matter more. Crouch gait can occur because of many more factors like liver and problems in the foot, and tibia derotational osteotomy can be done afterwards. Complication of over lengthening is genu recurvatum and anterior pelvic tilts. Now come to the gastrosoleus contracture, that is equinus contracture, but we have to bother about the hidden equinus, real equinus and apparent equinus, because we are going to do surgeries only in the real and hidden equinus. Apparent equinus don't need any surgery in gastrosoleus muscles, and it is also very essential to differentiate between the length of the gastrocnemius and soleus muscle, because both this method is required separate surgeries. This silver scaled method is tested for the length of the gastrocnemius muscle. Equinus contracture can occur because of gastrocnemius and soleus both. With knee flex, if knee is easily dorsiflex, then equinus is not because of the soleus. As knee extended, ankle again goes into the equinus, so it is because of gastrocnemius. So that we have to differentiate. Usually in diabetic cerebral palsy, gastrocnemius muscle is tight, but in hemiplegic cerebral palsy, soleus can also be tight along with the gastrocnemius muscles. There is different soft tissue procedure on calf birth correction of the equinus. In cerebral palsy, it is zone 1 surgery is very, very important. We have to be very, very careful in the zone 3 surgeries. Zone 1 is Brauman Strayer, zone 2 is Valpius and Becker, and zone 3 is White and Hope. And as I have told you that hemiplegic spastic cerebral palsy, natural progress is totally different from the diplegic spastic cerebral palsy. In hemiplegics, gastrocnemius soleus both are contracture. That means tendinochlesis is tight. But we can go by the zone 1 surgeries by giving the surgeries on gastrocnemius and soleus both. But it tight, tendinochlesis is too much tight that we can go for the zone 3 surgery, that is the tendinochlesis lengthening. In zone 1, Bowman aponeurotic release of gastrocnemius soleus both. Recurrence are common, but that is acceptable. Over surgery should not be done in these cases. In diplegic spastic cerebral palsy, usually gastrocnemius contracture is there, but we have to bother. But massive surgery in gastrocnemius can lead to the crouching of these children, and even the weakness of the gastrocnemius can occur. This zone 1 surgery, strayer release is ideal one. Soleus contracture is very, very rare. As you know that 1 centimeter lengthening of the soleus causes 50% reduction in the strength. So, TL lengthening causes weakness of the soleus, that means crouching, and there's more chances of overcorrection, that is calcaneal deformity. It is not acceptable. So, whenever it is possible, we should be managed it with botulinum toxin, bracing, therapy, and it's really required very tight and checked by the gait analysis and physical examination. Then we go for the surgeries in diplegic spastic cerebral palsy, especially for the gastrocnemius contracture. Tips and tricks: avoid surgeries before 8 years of age, detailed gait analysis, detailed physical exam, a reconfirmation of the finding under anesthesia is very, very important, essential, it is mandatory. Under correction is required in diplegic cerebral palsy, but we need complete correction in the hemiplegic cerebral palsy. We have to make detailed assessment of each and every joint in each and every muscle and bones, so that we can go for each deformity correction in single setting surgery, that is known as single multi-level surgery. Reduce recurrence of deformity by encouraging voluntary control by the regular exercises, promotion of ambulation and use of proper braces. Tackle problem at all level in single event surgery. Thank you.